Hello, everyone. I'm Dr. Sal Pacella. I'm a board-certified plastic surgeon out of San Diego and La Jolla, California. Welcome once again to the Beauty and the Beasts podcast. I'm joined by my good friend and colleague, Dr. Samir Jejurikar. He's the president of the Dallas Plastic Surgery Institute and a phenomenal surgeon, if I do not say so myself.
Okay. You do not say so. Wait a second. I saw what you did there.
All right. So we're going to talk about a great topic today. Fat, okay? Not
fat?
You being fat or me being fat, but
God.
adding fat into plastic surgery and plastic surgery procedures. So we're going to talk about everything from face to body to breast and everything in between. So fat transfer is a technique that I would say in the plastic surgery community is relatively new. New as in 10 years. Years ago, we didn't have much as far as technology for understanding how fat would survive in the body once it's taken out, reprocessed, and put back in. And I would say that in the last several years, that technology has changed. Tell me a little bit about the technology changes that you've noticed in the industry.
So I think to take a step back, the first fat transfer case that I saw was about 25 years ago. And you were there too.
Oh.
Or I was in Michigan. Hack Newman was doing fat transfer operations back then. Fat transfer was a really new procedure. There was a pioneer in New York City, a guy by the name of Sidney Coleman, who sort of invented these techniques, which have really, just blossomed from his initial research. And we would harvest fat very delicately using a syringe. We would take that fat, we would spin it down in a centrifuge, isolating out the serum, isolating out the oil, and then we would inject that small volumes into the face. And over time, things progressed there. When I was doing my fellowship in Manhattan Eye and Ear in 2005 to 2006, I actually scrubbed on I guess what you would call a Brazilian butt lift. It was the very first fat transfer I ever saw to the buttock, and it was with Dr. Coleman. Over 10 and a half excruciating hours, we harvested fat using syringes from all throughout the body, and then
1 cc at a time, right?
Injected it, yeah. And then at the end had enough to put in about 400 cc's per side. And my resolution that day is I am never injecting fat into people. So that was sort of where it sort of came from, is like a painful, excruciating experience. But I think, kind of talking what you're saying, in the last 10 years, it has exploded in popularity. And the first thing is just the concept of fat. Think about when I say fat, in general, that has a negative connotation. Nobody wants to be called fat. We view fat as being sort of the enemy cell in our body. We diet in a way to try to get rid of fat. We exercise in a way to try to get rid of fat. But fat is a really amazing tissue because fat brings growth factors with it, has the potential to create a lot of changes around there. So the first big change and the first thing in the evolution is how we think about fat. Fat is good. We use fat in so many different applications. We use it in the face, we use it in the body, we use it in the breast. When I harvest fat from the face and the body, it's a little bit different. From the face, it's a little bit different when I do it in the face versus the body. How about you?
Well, so I think, to dovetail on what you said here, fat is good. And in no other place is that as good as it is in the face, right? So I tell my patients, we've talked about this on other podcasts, one of the cruel tricks of nature is that the more fit you are, as you get older, the worse your face looks because you're losing that natural fat. So to me, re-injecting fat or redistributing or replacing fat in the face is a very key concept. To me, that's the best bang for your buck when it comes to cosmetic surgery of the face. It's a great adjunct as an alone procedure or adding with additional procedures. Let's take a second here and let's go over a couple photographs of fat. Should we? Okay.
Yeah.
So here are a couple examples of some patients, and they've had some fat transfer procedures to the temple area, to the cheek area, and to the face. And I think what we see with a lot of these patients is their skin consistency is very good, right?
Mm-hmm.
In patients who are candidates for fat transfer alone, those are patients with good elasticity of their skin. And so if they don't, we oftentimes have to combine some additional procedures, correct?
I completely agree with that. So, and I think the way we harvest fat to use in the face is still very similar to what I described with the Coleman techniques. That's still what I use, where we use a very low suction to harvest that fat. We handle the fat very gently. In different areas of the face, we might use different size particles of fat. Um, we might fractionate the fat or use nano fat for areas where we're injecting it more superficially. We're passing the fat back and forth between two syringes with a tiny filter between them to filter out the bigger particles. And what we're injecting, for me, it's the temples, the brows, the tear troughs, are fine microscopic particles and growth factors that change the properties of the skin. As we get lower down in the face, I use bigger particles that are more structural, cheeks, lines, marionette lines, things like that.
And what are some of the issues that you can see with fat transfer afterwards? Some of the complications you want to watch out for and avoid?
Well, I don't even know if it's a complication so much as it is an invariable way that fat responds. You will lose some of the fat, and you lose it relatively quickly within weeks to months of the procedure. I tell patients it's typically around 60 or 70% of the fat that they'll lose. Once you put in, and once it stays, it stays. It behaves like fat. Fat doesn't magically go away. But the purpose of fat is to store triglycerides, to use as an energy source. So if you get really lean, the fat cells shrink. If you gain weight, the fat cells swell. Years ago, earlier in my practice, I had a patient who had really significant asymmetry. So I injected asymmetric amounts of fat into different sides of the face, and then they gained a bunch of weight, and one side of their face got much bigger than the other side of the face. So I'm really cognizant to inject the same amount into this, no matter what existing asymmetries they may have.
That's a great point. Let's maybe move down south a little bit more. So let's talk about fat transfer to the breast. What sort of role does it have in your practice? Where do you use it? Where do you get the fat from?
Yeah. So I think as we start talking about the breast and even the body for that matter, the way we harvest fat is a little bit different for the purposes of efficiency. In the breast, in the body, we are injecting hundreds of cc's of fat as opposed to 2 or 3 or 4 or 5 into individual little areas. And so we need a more efficient way to actually harvest the fat. So if I'm doing a fat transfer to the breast, or if I'm doing a fat transfer to the buttock, which once upon a time was very prevalent in my practice, I will use liposuction. I don't particularly use low suction as well. And instead of going through a process of spinning down the fat, we use a passive system to let it separate. In the breast, I'll use some products, a surfactant to wash it till we get a more purified fat as well. But in the breast, and I think you'll agree, when we were training 20, 25 years ago in Michigan, we were basically taught that it was irresponsible to inject fat into the breast. The reason behind that was when you inject fat into the breast, it's thought to release growth factors like we've talked about, and we thought that would potentially promote breast cancer. I think the data is very clear since this time that fat to the breast does not cause breast cancer, but it can cause problems with breast lumps. Have you seen that where patients will get oil cysts or areas of fat necrosis in the breast?
Absolutely. So I would say, being a bit of a reconstructive surgeon as well, I do a bit of breast cancer reconstruction. And some of the things I learned, or most of the things I've learned in the world of fat transfer have come from my experience with breast cancer patients. And we're talking about trying to hide deformities of implants in the setting of mastectomy, trying to deal with issues related to radiation. And in the breast cancer world, we commonly see issues, probably in about a quarter of patients may have some cyst or some other fat lump or fat necrosis. Now, the good news with that is it's very treatable. So oftentimes what I tell patients is you're going to feel some transient lumps or bumps. If they persist for longer than a few weeks, I'm just going to have you work on massaging it. And I have them do things like direct pressure, vibratory massage, kneading, things like that. And that 80, 90% of the time that'll go down. And if it doesn't, it's a pretty easy fix to take out. Oftentimes it just means making a little small cut and milking the fat out. To get back to what you're saying about imaging in breast surgery after fat transfer, if there's any comment on safety in injecting breast or fat into the breast, why would we be doing it in breast cancer reconstruction, right?
Yeah.
And so, I think those things as we've gotten better with 3D mammography, getting better with ultrasound and MRI, those concerns are very minimal.
What I'm picking up from you too is that you use fat to camouflage things. You use it to camouflage implants, little contour defects. I think that, at least in my practice, the role of fat in the breast for massive enlargements just does not exist. In my hands, if someone asks how much bigger can I expect to get with with a fat injection to my breast, I'll tell them half, 3/4 of a cup size. If you want more than a cup size, I simply cannot accomplish that with fat, and most people cannot.
Right. And the physics of this is very important too, right? So, when we're talking about going from a B cup to a D cup with breast implants, right? We're taking an implant that's round and putting it into a semi-round position, right? Or a semi-round organ, okay? So you can get a nice round shape to this. When you inject fat into a breast, the fat is going to go at the point of least resistance. So it's very difficult, if not impossible, to get a big round mass of tissue into the breast.
Mhm.
So it oftentimes looks a little bit distorted. It's not incredibly predictable when it comes to changing size massively.
Yeah.
Okay. Let's kind of shift gears and talk about the BBLs. Okay. I know this is a procedure you do quite a bit in your practice, or have done quite a bit in your practice.
At one point in my practice, it was a very large segment of my practice. Now I still do. People still know me for that, but I don't do the same volume that I did. But I know a lot about the operation. BBLs are a very interesting cultural phenomena, where we have seen people wanting just gigantic buttocks, which they would be coming in for multiple rounds of these operations to get their buttocks bigger and bigger. Thankfully, that trend has gone away. And now what we typically see with Brazilian butt lifts are people that want an athletic looking buttock. There's some important physiologic and safety concerns with the operation though. Physiologically, the skin envelope on the buttock is not as tight as it is on the breast. So what I just told you about injecting fat into the breast and not get a big change in volume doesn't really apply in the buttock. You can get a substantially increased size in the buttock if that's something you desire. But safety concerns are obviously a must. So 2017, there was a paper that basically showed that there was a high rate of deaths happening in Central America and in Mexico. 2018, we discovered there was a problem in the US. And, in some parts of the world, they banned Brazilian butt lifts for a period of time. Thankfully, with a lot of great research that's come out, we've realized that if we inject superficial to the muscle, that you can do a very safe operation. So one of the take-home messages for anybody watching this podcast is if you want a BBL, if you can ensure that your surgeon is using ultrasound guidance so that it's being placed in a safe plane, you can get the operation done safely. If the surgeon doesn't use it, you can't have that certainty that you're not getting the fat injected in the wrong place.
So takeaway message from our podcast today: fat is a exceptionally useful tool. We have to approach it with caution, and it's very reliable.
Agreed.
And I think we'd like to call it liquid gold, right?
Cheers.
Thanks for joining the Beauty and the Beast podcast.